Dear students, as strangers, our meeting in such environment will seem. I think that you took it as a forced measures and the university administration is forced to take these steps only because of the desire to provide your education without interruption. As the Department of Oral and Maxillofacial Surgery, we assure you that in your video presentation and online classes, we will try to solve all of questions included in the educational program. I inform you that our department has some experience of distance learning. Personally, I conducted online lecture for students of the stomatological faculty while I was on a foreign trip. A direct interactive connection between the lecture hall at the surgical clinic, medical university, and my place abroad was established. Thus, a lecture session was held according to the study schedule, and my scientific trip was continued. This lecture will be recorded on the video, and we cannot communicate it interactively. But I am ready to answer all of questions that arise during the presentation, as well as any other question of the curriculum. Questions can be sent to our website, and you will be received to answer them. This will be our connection to National Action Program, FDAGAL, and will demonstrate our readiness to fight the coronavirus. Now I would like to introduce our lecture, the themes of our lecture, surgical aspect of dental implantology. I would like to give you basic principle, these themes. What topics will be discussed? First of all, I would like to explain you what's the aim of dental implantology. I will give you terminology and the history of dental implantology, anatomical and physiological features of mandible and maxilla, classification system useful in dental implantology. I would like to inform you about design of dental implant, mechanical principle of dental implantation, and biological background of osseointegration. The features of the preoperative examination of the patient and the preoperative planning of the dental implantation. Indication and contraindication for dental implantation. I will give you medical legal documentation for dental implantation. Equipment, instrumentation, and aesthetic requirement for dental implantation. Surgical procedure of dental implantation 1 and 2 stage surgery. Immediate and long-term complication of dental implantation, and will give you classification of peri-implantitis and his treatment. If God does not want us to have the teeth, He will never give us the conflict of teeth, decidus and permanent. Despite of His gift, for most of us it's not enough. Nowadays, development of the dental implantology enables of the third conflict of teeth. The aim of dental implantation is to restore missed anatomy, function, and aesthetic of dental-alveolar systems. Increased interest to this field and the number of publications, the recent 20 years, lead to some terminological mistakes that requires the explanation. The implant, this is the transferred tissue. Medical means which was invented to the human body to replace the missed organ. Implantation, transfer to the artificial material to the biological system. Dental implant, the implant which are the place of the mandible or maxilla to the start point of the removable or non-removable prosthesis. Dental implantation, it is a surgical method insertion of the roots to the mandible or maxilla. In maxillofacial surgery, besides the dental implantation, we can use maxillofacial implantation. Maxillofacial implantation, insertion of the implant to the facial skeleton surgically in order to achieve the stability for removable or non-removable maxillofacial prosthesis. Sometimes we find the wrong terminology. If you know, implantat is a Russian and Azeri slang, but the wrong pronunciation, implantant. The English version, the correct terminology would be implant. In the old international terminology, dental implantology were recognized as allotransplantation, but allotransplantation is transferring to the organ or tissue from human to human. But the new international terminology, dental implantation were recognized as explantation, because explantation is explantum, the foreign plantare insert. In scientific literature, there is only widely used term, implantation. The history of the implantology would decide on the teeth that were fabricated from the object of wilderness, transplantation of the teeth taken from the individuals, teeth were manufactured from the chemical elements, modification of dental implant design, body response to the dental implants, and ideal material for dental implant discovered, improving the design of the dental implant, and will give you information about development of the dental implantology in Azerbaijan. The problems of the repair of loose and destroyed teeth distribute humanity. The archaeological investigation in China, Egypt, and Central America showed the attempts to this kind of reconstruction. The method of reconstruction, such as by stones, gels, precision metals, elephant ivory, were not. 6th century before Christ, teeth that were fabricated from the object wilderness. In Harvard University Museum being considered the archaeological findings since the ancient Inca epoch. The mandible, in which the 41, the 31 teeth was replaced by cochlea. In the 6th and 18th century, it gives the first scientific notes according to transplantation and implantation teeth by Spaniard Alabas. But up to the 18th century, it wasn't used in the clinical practice. In the 18th century in England, poor individuals sell their teeth to order to be implanted to rich person. If you know, it's an allotransplantation. The Victor Hugo, in his novel Outcast, shows the phenomena. However, the spreading of the infection makes this practical usage limited. In 19th, 20th centuries, one continues search of ideal materials for the teeth manufacturing. Up to introduction to principle antisepsis, the infection and non-union implant are the frequent cases. The use antiseptic for disinfection of surgical wound is resulted by decreasing in the infection rates and would direct the scientific to search of the proper material for dental implant. The next steps, this manufactured from the chemical elements. If you see on this slide, the different elements we use it for the manufactured implant. Aurum, platinum, the silver, iridium, titanium, lead. And the alloys used for manufacturing of the dental implants: molybdenum and steel alloy, vitalium, gold, platinum, platinum, iridium, and chrome cobalt. The modification of dental implant design, the 1990 Greenfield manufactured implant from the platinum that had basket-like design and specially case for crown fixation. In the 1938, Stroke discovered the root shape, the screw-like design of dental implant manufactured from the vitalium, which was inserted immediately after tooth extraction. And very interesting, that implant that was inserted to the patient had 40 years long-term result. The 40 of 19th century, the Swedish dentist Dalte suggested subperiosteal implants. However, in Sweden, this kind of implant was not accepted by the medical society. Therefore, the scientist was obliged to immigrate to the United States. In the United States, subperiosteal implants are useful today too. In 1947, Italian physician Fromigi suggested a new design of implant and proven that intraosseous implant could be a good support for dental prosthesis. In 1964, Small suggested transmandibular implant for the mandible with acute atrophy. The main features was that there should be fixated both on oral aspect of the mandible and the inferior border of mandible. It could be used for full prosthesis fixation. In the middle of the 20th century, numerous experiments were done on the animals for analysis reaction of tissue to insertion of dental implant. Pasquale discovered absolutely new kind of reaction of the bone against the insertion of dental implant. The production of the connective tissue around the dental implant manufactured the form vitalium and binary alloys, which have functional features. But finally, the ideal material is found for dental implant. 1952, Swedish scientific Brannemark discovered the phenomenon of osseointegration. Artificial material could connect with bone biologically. It's his idea. After creation of atraumatic cavity with the bone which fits on the titanium construction, the firm connection between the pure titanium and bone will develop. Now I'd like to give you information about the history of dental implantation in our republic. During the Soviet Union, Azerbaijan, they were forced and conditionally execute the decrees of the censure. Thus, between 1956 and 1986, dental implantation was officially banned, the forbid for use it. Only 1986, 30 years after world-renowned opening of the Brannemark of osseointegration of dental implant and bone tissue, the Ministry of Health of the USSR, by its decree, gave the official permission for this activity. And following, Azerbaijan was placed to introduce dental implantation in the country. Unfortunately, Until the late 1990s, the first failed implantation attempt dissuaded the local dentists about feasibility of this technology. At the time, I conducted an informal survey among dentists and different social conditions of the patient about how they see the introduction of dental implantation of the treatment process. The following are a result of research. Most dentists state that it will not get anything. Another opinion, our patients are not ready for this, or I have enough patients and they are filled with my treatment. The patient says, this may lead to diseases oncology, my honor will be down, and etc. With this in mind, I decided to first of all ensure of the educational level of local specialists in the field of dental implantology. By conducting scientific and practical course with the participation of foreign specialists, the first for doctors and then for dental technicians. Some local experts responded to this initiative. At the present, dental implantation is widely implemented in Azerbaijan. We have the specialized society, large-scale international congress, Hazar, hundreds of courses of scientific and practitioner courses and organized during the year. The subject of the dental implantology is introduced into the educational process of the medical university. Scientific research works are being carried out. Then late we connected, but already we have the worst image in the world community of implantology. What's mean osseointegration? It's connected between live organism and manufactured implant. Biostructure, maxilla and mandible belong to the musculoskeletal system of human. This structure, by creating individual occlusion, are playing the role of the mastification, breathing, swallowing, and speech. They are also forming the facial appearance. The both maxilla and mandible are covered by the periosteum. The outer layer of the bone is a compact bone, but the inner one is the cancellous. Architectonics of the bone, there is defined the proportion of the compact and cancellous bone. Maxilla compact plate have the approximately 30 % cancellous bone in the 70, the proportion 1:3. Mandible proportion 1:1. Therefore, the bone architectonic of the maxilla and mandible is different. About bone quality, we have the classification by Lincoln and Zarb. D1, the large homogeneous cortical bone. D2, thick cortical layer surrounding the dense medullary bone, 1:1. D3, thin cortical layer surrounding a dense medullary bone, type 1:3. And D4, thin cortical layer 1 or 2 millimeters, surrounding a sparse medullary bone. In microstructure vision, osseous tissue is composed of the cell of osteoblast, an intracellular substance osteoid. Inner surface of periosteum is producing osteoblast, providing the bone growth and regeneration. Compact bone of osteons, they are forming the concentric ring that surround vessels. This is the Haversian system. Here one could find osteocyte. The cancellous bone is comprising the trabecula and cavities. Depending on mechanical loading of the orientation of the trabecula could be changed. Within jaws, on the sides of maxilla mechanical loading, attachment to the muscle. The cortical bone becomes thicker and trabecula acquires specific orientation of the former partres. Now I will show you the process of jaw atrophy changing of facial appearance. If you know, the maxilla and mandible is forming by teeth development. After tooth loss, the functional loading is decreasing. Therefore, the changes in the bone architectonics occur. The atrophy process taking the place more of the region that receive the more functional loading and have more cancellous bone, the lateral part of jaws. And the later site of atrophy is symphysis of mandible. In the maxilla, you can see the same process, and finally you will see the change in the facial appearance. Here's in details the maxilla and the alveolar ridge without tooth, the long-term period after losing the tooth. If you see, you can compare the maxillar bone with tooth and without tooth. The mandible alveolar crest atrophy were showed by the classification Alwood. In the first class, dentate alveolar ridge. The second class, post-extraction alveolar ridge. The third class, high alveolar ridge. And the fourth class, high but narrow alveolar ridge. The fifth class, semicircle or flat alveolar ridge. And the sixth class at the concave and the flat alveolar ridge. The same classification for maxilla was done by the Falschult in the 1986. We cannot see here the zero class with tooth, but the first class, the alveolar ridge without tooth, the enough the high and the enough wide. The second class, high but narrow alveolar ridge. The third class, high and sharp alveolar ridge. The fourth class, low because resorption and wide alveolar ridge. And the fifth class, total resorption of alveolar ridge. Now I would primary healing of the bone is harvational osseous remodeling. At the beginning of the bony wound is filling by the blood and response against the injury is taking place on cellular level. Within Hamversian canals begins the process of bone healing. The osteoids in between wind edges and forming the primary lamellar bone breadthways, creating bony bridge. This process could be called as Hamversian remodeling of the bone. The secondary healing of the bone is a non-physiological condition. If there is any cases of the interferes at the physiological healing, it is infection, white site of injury, the purpose of bone healing have different courses. Within the vast amount of soft tissue, one could find the rupture of the vessels and accumulation of hematoma. The vessels that are localized in between the bone and soft tissue are rupturing and inside the bone, and also could find the hematoma. Within bony cavity, hematoma slowly is turning into granulation tissue, and the granulation tissue is turning into connective tissue. Today, we should definitely accept that dental implantation should be done the implantation material, the implants that have the features of the biomaterials. Implant artificially created material that is embedded in the human body. The material that are using for manufacturing of dental implant should integrate with biosystem. The biomaterials, artificial material that is used for medical purpose and the integrating with biosystem. Therefore, dental implant should be biomaterial. We have the requirement to mechanical and biological features of dental implant. The material of ideal implant leads to create certain physiological reaction which should destroy it, and being itself resistant to corrosion, resorption, and elasticity. The material that are using for manufacturing of the dental implant should meet the cases and being non-toxic, non-carcinogenic, non-allergic, and non-radioactive. With the take into account of the repair of periodontal ligament around dental implant is impossible, one should think about different type of function. The mechanical junction is the primary junction of the dental implant with the bone that is based on the mechanical principle. Inserted implant should be stable within its socket. Biological junction, insert implant is the establishing solid junction with bone that is based on phenomenon of osseointegration discovered by Brannemark. This secondary and durable junction. During creation of socket for the dental implant, the bone is showing response to this action. First of all, tissue response, it may be vascular response and inflammatory phase, starting immediately and lasting 24 to 48 hours. The B stage is proliferation. It has two phases, the first and second osteogenesis phases. The first stage of osteogenesis, starting the 48-72 hours later, the process of osteomyelation and the vascular growth is taking place. This stage is lasting 12-15 days. The second stage of osteogenesis, so 7 days later, first bone resorption. Osteoclasts are destroyed the structure that don't have vital importance, and informed cavities could be newly bone and basal. On initial stage, the process and cancellous bond is taking place. The next stage is a remodeling stage. Starting since the 4 or 6-8, cancellous bond is replaced by the laminar bond, so this process is ending on the 12-16 week on the mandible and the 16 and 24 weeks on maxilla. The first stage, this is inflammatory response. While placement of dental implantation in the bone socket, one could note immediate tissue reaction, vascular reaction and inflammation, so this process lasts 24-48 time. Here is the surrounding the implant. We can see the lot of elements or the blood elements. In the proliferation stage, the beginning is the 48-72 hours later. After this time, the proliferation of new vessels and osseous islands occur. The second stage begins 1 week later. The first of resorption is taking place. Osteoclasts are destroyed, the structures that don't have vital importance, and they form cavities and can be found osteoblast and the osteoid. Finally, remodeling. This is 6 or 8 weeks later. The process of the bone formation continues, and it will be end in the 12-16 week on the mandible and the 16 and 24 week on the maxilla. Now I would like to inform you about the different type of osteogenesis. This is the contact osteogenesis. What's mean contact osteogenesis? The osteoblasts are primarily situated on the surface of the implant and covered its surface completely. Thereafter, the proliferation is taking place from implant surface toward the walls to bony sockets. There are no other element, blood component, between implant surface and walls of the bony sockets. So implant connect with bone directly. Its characteristic typical for bioinert materials, like the titanium. The other osteogenesis type is distant osteogenesis. If you see on this slide, osteoblasts could not primarily be situated on the surface of the implant. Process ossification is taking place in direction from the walls. This is walls of alveolus. From the walls of bony socket toward the implant. In this case, between implant and the walls bony socket, one could find other element, blood components, so process of ossification could show down. Other types of junction is a fibrin integration. If process of osteogenesis between implant and bone is not occur, then in between the structure and fibrous tissue will arise. Thus, implant will be surrounded by fibrous tissue, and this kind of junction is known as fibrointegration. If you see, between bone and implant, we have connective tissue. The next types of junction of the dental implant with bone is biointegration. an attempt to increase the quality of the junction between implant and bone by using bioactive materials. By application of nanotechnology and surface on dental implant is coated by synthetic heteroapatite that is stimulating accumulation of collagen fibers on this surface so implant connect with bone by natural junction. The mechanical features of the implant material is ability to resist external loading. This loading is different groups of the teeth is different. Molars and premolars is approximately 200 and 800 Newton. In some cases, it can be increased to 2,440 Newton. But incisive and canines, it's only 50 or 200 Newtons. Solidity of the implant material is determined upon its degree of deformity and compression from external loading. This could be accessed by utilization by Young and Poisson models. The Osborne opinion, materials that have a good biological quality have a poor mechanical quality. And the terabyte today, the most appropriate material for dental implant is bioinert material. In such cases, around dental implant occurs contact on osteogenesis and between implant and bone osteointegration. Titanium, this is the fourth class pure titanium, and the fifth class is titanium vanadium aluminum alloy. What's characteristic titanium? Elasticity is 5 times more than bone. Density much more solid than other materials. Ability to integration, this is bioinert material on the surface of implant forms stable and relative inert oxide layer that leads to contact to osteogenesis. But unfortunately, resistance to friction is very low. In order to increase the resistance, one is to treat implant surface by plasma. Dental implant could also be manufactured from zirconium dioxide. Despite of excellent aesthetic, this osteointegration is pure, unfortunately. Therefore, application of dental implant manufactured from the pure zirconium are limited. Today, Straumann company manufactured implants that are fabricated from titanium zirconium alloy. The name of this implant is a rock solid. Dental implant, being biomaterials, are designed from the long-term usage. Another type of screw-like biomaterial that could be embedded to body for rigid fixation of the fracture treatment and don't have the special processing of the surface in the temporal fixation devices. There are a number of the types of dental implants for long-term usage. In the classification of dental implants depending on design, we have the root shape, like the tooth root. Among these, the screw-like and cylinder-like. Other type of dental implants is the plate-like and superiosteal implant. The very important characteristic of the implant is its size. The definition of size of dental implant included diameter and length. as long implant was inserted, as more contact with bone could be achieved. That's leading to increasing the resistance of the bone implant and bone toward functional loading. Increasing implant diameter is leading to increase this mechanical resistance that resulting but more rational spreading of the functional loading to the bone. The size of the implant depends on anatomical characteristic of the bone. Anatomical composition of the mandible and maxilla determines the size of dental implant. While implementation of dental implant by taking into account the clinical, biological, or biomechanical principles should choose implant with adequate size. Here is the principle, the quantum satis. Due to that manufacturers offering the implant with different size. And the other important characteristic is the position in the implant. In order to achieve the adequate osteogenesis and ensuring the further prosthodontic rehabilitation while drilling of implant holes, one should follow several rules. First of all, the distance from the crown of adjusted tooth to the central axis of the implant should be 4 mm. It's for single root, but 6 mm for the multiple root tooth. The distance between central axis adjacent implant should be 7 or 8 mm. Distance between the lateral surface adjacent implant 3 mm, and the distance between lateral surface and implant and adjacent tooth 1.5 mm. The volume healthy bone around implant should be more than 1.5 mm. The distance between dental implant and inferior alveolar channel should be less than 2 mm. According to this design, we have the two different types of implant. The single component and multi-component implant. Single component implant used for single step or one stage implant. Each single component divides the component implant in the intraosseous part at the fixture, neck implant and head of the implant. It's the one piece implant. But multi-component implant are using for double step implantation. It's a implant fixture, suprastructure, and the abutment screw that connected these two parts. According to service design, we have different types of implant. If you see here is the smooth type, service very smooth, machined, fabricated the special, the screw form, textured and coated by bioptic material. It's natural that the textured surface of dental implant increases the contact of the surface with bone. Moreover, it was proven that textured surface increases efficiency of the integration as well. The plasma splay can be increased the surface for contact with bone. For primary stability, it's necessary to achieve the dental implant as screw-like design. Depending on bone quality, dental implants have different depths, pitch, and width of the threads. Furthermore, if we have the bone at type D1 or D2, it's necessary to use the implant with less deep, blunt, and less pitched threads. For bone D3 and D4, threads are deep, sharp, and have big pitch. In order to achieve the connection with bone, the connective tissue is responsible to create the texture design of the part of the implant that will be inserted into the bone. In order to achieve the connection of gingua, here is the epithelial tissue. In some implant system, on create the gingual part, this tooth. If you see the A tissue level dental implant, we can use this implant in the posterior part of jaw, and the frontal part we're using usually bone level implant. Microscopically, we can see if you will be the more than 5 times, and the 15 times, and the 25 times. If this is like the crater, the most appropriate size for voids for osteogenic cells is 70 to 700 nanomicron. But sometimes we have the problem with implant with rotation. For anti-rotation, the system, the implant has the special, the prevent and twisting of the dental implant is proved by a special design. Double-ended aperture, and the cutting edge. The requirement to utility and the functionality to dental implant, the dental implant should be qualitative standpoint for prosthodontic device that quality high functional and aesthetic demands, should maintain hygienic and healthy status of oral cavity, should be radio contrast for controlled by X-ray. Surgical and prosthodontic trays should be as simple as possible. As appropriate, should have the possibility to remove the front bone, sterilized, and should not be too much expensive. But each of surgery is necessary the planning before. The planning of the surgical step of dental implantation, here is the better safe than sorry. Planning dental implantation is complex measures that is aimed to avoid possible complication and increase the quality of treatment. It's natural that beside the successful result on the good face with unsuccessful one, but increasing number of conflicts between patient and dentist as well as judicial proceedings make it important and successful treatment for more actual. Therefore, every clinical case should be appropriated individually. To preoperative planning belongs implementation of clinical and instrumental examination, identification of indication and contraindication to procedure, objective assessment of quality of the bone, planning of surgical procedure, and if possible, application of digital technology. The clinical evaluation, here is this, first of all, it's necessary to collect the anamnesis data. What consists of anamnesis data? It's when and because of what reason this loss happened. Was any prosthetic construction used? What's the expectation of the patient from the dental implantation? Result of clinical evaluation, the status of dental arch, status of occlusion, type of adentia, status of oral mucosa, quality and quantity of oral fluid, status of oral periodontal tissue, hygienic status oral cavity, and psycho-emotional status of patient. In a radiological evaluation, the equipment special for radiological is orthopantomography and CBCT. It's called BMCT. What we're defining is a radiological evaluation. First of all, selection of appropriate dental implant type, size, and so on. Degree of resorption of the maxillary mandibular bone in the region of the implant insertion. Anatomy inferior alveolar channel. Anatomy of the maxillary sinus. Anatomy is the nasal cavity. Upon the data clinical and radiological evaluation, one should establish a diagnosis based on classification system. The indication, a limited defect of dental arch in the order to avoid the preparation of the adjusted teeth. Wide defect of dental arch in order to avoid the preparation adjacent teeth and using prosthodontic device. Terminal defect, sometimes we have impossibility to have application non-removable prosthodontic device. Instability prosthodontic device in case of total secondary adentia. And allergic reaction to components of acryl and high vomiting reflex. And the contraindication, we have the general, you can see on this slide, and local. Very important to have the objective information about this, because it will be solved what's this patient what we have will be problem in future. But nowadays we have the more the indication compared with contraindication. The Mitch and Judy in 1990 give for us the special classification for endothelial jaw. You can see here, and in this slide, what size it's necessary for group A and the group B. In other slide, we can see the group C and group D. And the partial endothelial jaw, Mitch and Jude give for us the other classification. Here is the group A. We can see adentia in the posterior part of jaw and maxilla. And here one of part of it we can the defect on the posterior on the maxilla, but on the mandibular we have the defect, we have adentia in the other part. In the group A we have fourth class. Here we draw all of class on the picture. In the group B, we have the other size. Here is the atrophy process is growing, and we can see the other measurement. And the same fourth class for group B. Group C, the identity grows more, and we can see the atrophy process in the posterior part of maxilla and mandibular. Here is on the left side of the maxilla and the right side of mandibular. Here the vertical bone resorption, and we have sometimes the bone resorption on the frontal area at the fourth class of group C. And finally, the group B, the severe total bone atrophy with adventitia side of maxilla and mandibular. For each of the classes and group, it's necessary to find the appropriate surgical planning. The history, the planning of surgical procedure, inside the specially designed prosthesis and placed the radiocontract balls in the region of purposed the places for implant and determining the exact localization. The direction of dental implant determined by the special transparent surgical guides. But now we're using navigation dental implantation, but means the virtual planning. A digital technology comes in dental implantation and makes preoperative planning more rational. But all of this information is necessary to should take into account both legal and dental logical aspects. The patient is necessarily informed about our planning, about what we're going to do. We prepared the special book, The Maintenance of Dental Documentation in Implantology. Here is we can find the types of agreement using for dental implantation, patient agreement for dental implantation, medical chart of patient for dental implantation, recommendation give to patient after dental implantation. This workshop was added to additional educational program for students of faculty of stomatological faculty. Clinical implementation. But first of all, it's necessary preoperative preparation. Some surgeons are performing dental implantation in such condition. Modern operation theater room that's meeting all requirements for dental implantation. Dental implantation should be performed in this operation theater room that meet high standard of asepsis and antisepsis as well as sanitation and being equipped by all of necessary dental and surgical hardware. The schematic of our operation room, you can see the hygienic area and sterile area, and the placement, the surgeon, the assistant, and the surgical nurse, where is it necessary to stay at the operating table, and technical staff. If it's necessary, we can invite the anesthesiology team for our surgery. Therefore, the number of persons, including medical and technical staff, should be 4 persons, minimum 4 persons. What's special instrumentation for dental implantation? This ratchet instrument required for implant insertion and force determination have Newton gauge. Implant drive necessary for insert implant in the bone without touching by hands. Over complex of dental system have the owner this implant drive. Parallel pins at multiple using tools that helps to determine parallelism of the implant. And all of other detail for surgical steps here consist in the surgical instrumentation tray. But for surgical instruments that are using during dental implantation, one have prepared the sterile surgical table. And illumination can be more than 300 lux. But very important, one of the very important equipment is the surgical sanction. If you now, when we open the place for implant, we can use special drilling. When we're drilling the bone, we have the mechanical damages the bone area. During creation of the drill hole for dental implant, could we find the bone necrosis around drill hole? The 1.5 millimeter. The other problem is the thermal damage. It's more than problem because the more due to friction in between drill and bone, one could be find everything the thermal damaging that increases necrosis site 10 times more. If we have overheating more than 4, if you know that normally we have temperature in the bone 36-37 degree Celsius. If will be overheating 4 or 5 degree of Celsius, bone marrow will be hyperemia. Overstanding 10 or 13 destruction of collagen, and more than 10 and 13 denaturation of proteins, destruction of osteocytes, violation and vascularization, breakdown and osteogeneration. In order to reduce the influence of traumatic factors, there should be used the special equipment and the special surgical protocol. That we have the electrical micro engine, angleless surgical handpiece with low rotation speed and the 20-to-1 reduction, as well as step-by-step widening of the drilling hole by using calibrating drills with different increasing diameters. More than one, we use the special equipment, physio dispenser, that is pumping the cold saline solution to work into drill and that cool down the bone, avoiding overheating. The special preparation for surgical patient for surgical stage of dental implantation. In order to reduce the psycho-emotional stress of the patient, should be prescribed the 10 mg diazepam a day before surgery. Directly before surgery, one will have to use the IV sedation. The oral cavity should be irrigated by 0.2 % chlorhexidine solution, and face should be disinfected covered by drapes. One has to perform local anesthesia. Here you can see the first surgical step by step. The first of all is necessary surgical incision. Carry out up to the bone and project an alveolar crest. Mucoperiosteal flap should be elevated, and we have to expose the bone. The cortical bone plate is drilled according to surgical guide, where it will be access the implant. Within the projection of the created drill holes, and we have to use the pilot bore, we order determine the implant length. Yes? And we have to use a parallel pin to create the drill hole for next adjacent implant. But maintain the steps of surgical protocol, one will have to make a step-by-step widening of the drill of holes for implant. Now implant inserting into creating drill hole, and its internal thread is blocked by covering screw. Mucoperiosteal flap is returning the back to the place, and when performing wound closure. The second surgical step, the different on the mandible and maxilla. And the mandible, we can be open this area after 3 months. On the maxilla, it's necessary for them the 6 months. On the second stage, the mucosa over cover inserted. Implant should be incised, covering screw being removed, and one have to insert healing cup screw. Therefore, the dental implant is ready for prosthodontic reconstruction. If I will ask you who is experienced doctor, it's necessary to say the experienced doctor who solves all of problem, but problem with dental implantation is complication. The results of dental implantation should be assessed by following criteria: clinical evaluation, but it's necessary to determine the stability of dental implant; radiological investigation by OPG или CBCT Conbium; resonance frequency analysis is determining coefficient of implant stability in the bone by ultrasound; and questionnaire. What means successful result? Successful result when we have absence of bone resorption around the dental implant, but that's confirmed by radiological investigation within 1 year period of time. The bone atrophy less than 0.2 millimeter. It suggests arboretism. International statistics on dental implantation on the world, 95% successful result. It's very high reading. And the 5 unsuccessful result. For us, it's necessary to know what cases with unsuccessful results. We have 2 types of cases: biological complication and mechanical complication. The mechanical complication joined with a manufactured problem. This is the crack of implant, fracture of implant neck, rupture of internal thirds, and fracture of screws that connected implant and abutment. By biological complication, a failure of osseointegration before prosthetic steps, failure of osseointegration after prosthetic steps, and resorption of the bone around dental implant. But what's causes of reason of the osseointegration failure? Violation of surgical protocol, low quality of the bone, and improperly done selection of dental implant. The violation of surgical protocol is the breakdown of the sepsis and antisepsis, bone overheating, bone compression, breakdown of primary stability of the implant, and premature loading of the implant. We say about overheating problem. The bone should be overheating more than 10 temperature when you have the denaturation of the denaturation problem. If you have normal, that's 37, and we have 10 grados more, its maximum temperature up to 47. If it will be more, the osseointegration process could find formation of connective tissue, capsule, or bone resorption. The reason here, the denaturation of protein. The clinical science, after 3 days after surgery, the outpatient can be feeling the acute pain in the region of the insert implant. Unfortunately, in the X-ray vision, we cannot see in the early stage. Only we have the fibra integration or resorption bone. We can check on the X-ray vision. But overheating can be not only the preparation implant socket and during insertion bone implant too. Bone compression at the stress in the bone during implant insertion as the cutting of the edge of the implant treats and producing sliding stress. This is sliding stress. The body is implant is producing compression stress and tensile stress. We have the different type of stress, if you see on this picture. This stress, they keep provoking occlusion of harvesting channels, compromising of vascularization that might lead to slowing down the process of integration and some practical cases of integration failure and forming fibrous capsule around the implant, instead the newly formed bone. Sometimes we have problem with during implantation. Perforation on the low border of mandible or injury inferior alveolar nerve. On the maxilla, sometimes pushing the insert dental implant in the posterior aspect of the maxilla bicortically could lead to penetration of the maxillary sinus or perforation of the Schneiderian membrane. Staying in covered this implant could be infected. The same situation can be on the found at the penetration of the nasal cavity. During implant insertion, we have the chance to measure the primary stability. During implant insertion, by the means of the torque K, could access implant mobility, subjective method, and objective method. After implant insertion, one could use a special ultrasound device in order to access solid injection of the implant with bone. Implants that do not have primary stability should be immediately removed and replaced by implant with large diameter. Because the very important condition during dental implantation ensuring the primary stability. When primary stability was achieved in between dental implant and bone osseointegration taking place. But sometimes we have this problem with dental implants. It's a dental implantation of the maxilla. But in these cases, dental implantation into maxillar sinus due to lack of primary stability. This complication usually related with breaking down of the surgical protocol. In this case, a dental implant should be immediately removed from the maxillar sinus by the means of the additional windows in its lateral part. But now I would like to show you the complication during the osseointegration period. The primary complication related with residual infection on the implant socket, complication related with other drilling of the bone, complication related with the fibrointegration instead osseointegration. And the secondary complication in the peri-implantitis and overloading. Any mechanical influence that could disturb stability of the dental implant during the period of the osseointegration could be lead to its breaking down. Mucositis. Sometimes we say this is the first steps of the peri-implantitis. Compared with peri-implantitis, here we have not bone loss. Here is inflammation on the tissue around dental implant, tissue hyperplasia, bleeding, and pus exudation during palpation or probing. But we have two types of mucositis, level OA and level OB. We measure the depth of pocket. If more than 4 is OB. But now we say about the peri-implantitis. The first class peri-implantitis is the same situation on the soft tissue as like the mucositis, but compared with mucositis, we have now the bone loss. The bone loss no more than 3 millimeters. We can treat conservative periodontal therapy. If it will be non-effective, it's necessary surgical correction. It is a curettage, antibiotics 1 week, and antiseptics for oral antiseptic healing. The second class, now we have the bone resorption more than 3, but not more than 5 millimeters. The treatment here is not necessary only surgical correction. Here is not necessary the correction of alveolar process, and again antibiotic and antiseptics. Third class, bone resorption more than 5 millimeters. But here is it necessary alveoloplasty and the sometimes it will be necessary implantoplasty, smoothing of the visible treats of the implant. The first class peri-implantitis, we have the bone resorption more than 50% of the length. But here is a treatment. If implant is stable, reconstruction of the cerebral integument by means of the guided tissue regeneration. Sometimes we have the mechanical complication. If implant with low quality, application of the access force during the implant insertion, and breakdown of surgical protocol due to skipping of bone quality. But usually we join the complication with low quality of the implant production. Conclusion. We have the successful rate 95-98 cases. In order to achieve such result, we have to form an integrated team: the surgeon, prosthodontics, dental prosthetic, patient, prothetist, patient, and hygienist. Now I will give the question for self-control. If you will have any question, additional question, you can send your question to our website, and just time you will have the answer this question. Here is the literature what I'm using for preparation this presentation. See you for the next lecture featuring.